Hello dear friends and colleagues. Today I will talk about Hammersmith Neonatal Neurological Examination or HNNE. I will discuss about the scoring system of HNNE and I will demonstrate the neurological findings in a baby. HNNE was designed to evaluate the neurological status of both preterm and full-term newborns. It is very detailed and systematic tool. It was developed in 1981 by Dr. Lilly Dubowitz and Professor Victor Dubowitz and updated in 1998 by Dr. Eugenio Mercari. So we have to know the significance or importance of HNNE. What are the importance of HNNE? It helps in early detection of neurological abnormalities in newborn. Second, it facilitates timely intervention. And third, it is essential for improving long-term neonatal neurological outcome. And this HNNE can be done in term equivalent age for preterm infants and in term infants up to 4 weeks. There are total 34 items which are grouped into 6 categories. These 6 categories are posture and tone, tone pattern, reflexes, movements, abnormal signs and patterns, and orientation and behavior. In posture and tone, there are total 10 items.
First, look at the posture of the baby in supine position. Look mainly at the position of the legs, but also note the position of the arms. Posture is abnormal if strong arm flexion or marked extension of the legs or opisthotonous posturing is present. Forearm recoil test. Infant should be in supine position with head in the midline. Then hold both the wrists and gently flex both arms at the elbow, bringing the forearm towards the upper arm and hold the arms in this flex position for 5 seconds. Then extend the baby's arms fully, and quickly release the extended arms. Now observe how quickly and fully arms return to the flexed position. Repeat this test for thrice. The speed and degree of recoil are used to assess the passive flexor tone of arms. Forearm traction. Hold one wrist and pull the arm upwards. Note flexion at elbow and resistance while shoulder lifts off the bed. Test each side separately. Foreleg recoil test. Hold both the ankles, then flex hips and knees. Then quickly extend the lower limbs fully and release. Repeat this for 3 times and note the response on each side. Foreleg traction. Hold one ankle and slowly pull the leg upwards. Look at flexion at knees and resistance when the bottom lifts from the surface. Test each side separately. Popliteal angle measurement. First fix the knee on stomach, then extend leg at knee by gentle pressure from first finger at ankle. Then note the angle behind knee. Test both sides separately. Head control test to check for extensor tone of the neck. First hold the infant upright in sitting position. Then encircle chest with both hands holding shoulders. Then let head drop forward to look for an attempt to raise head. Head control test to check for flexor tone of the neck. Let the head drop backward to look for attempt to raise head. To check for head lag, first pull infant towards a sitting posture by holding at the wrists and support the head slightly, then look for attempt to raise the head. For ventral suspension, first hold the infant in prone position by lifting horizontally under the abdomen. Then look at the curvature of back, flexion of limbs and relation of the head to trunk.
Here I will discuss about the scoring system of HNNE. This is different from other scoring systems because here 2 types of scoring system is there. Raw scoring and optimality scoring. First is raw scoring. Each of the 34 items within the 6 categories is scored from 1 to 5 depending on the response. But if the response falls between 2 columns, it is given a score of 0.5. But drawback of raw scoring is that raw scoring doesn't define the normality because the normal range varies with the gestational age. Here is the importance of optimality scoring. Optimality scoring is conversion of the raw scoring into optimal or suboptimal values. These optimality scores are assigned to 0, 0.5 or 1. In the HNNE Proforma, there are three types of color coding system: highlighted gray box, light gray box, and white box. In the highlighted gray box, represent raw scores fall between the 10th and 90th centile of the respective population, and these are assigned an optimality score of 1. In light gray box, 5th to 10th centile and assigned to 0.5 or borderline, and white box represent raw score below that 5th centile, and these are assigned a score of 0. So global optimality score is sum of the optimality score of all 34 items. Maximum global optimality score is 34. And what is the interpretation of this GOS? Global optimality score more than equal to 30.5 is normal for term infants, and more than equal to 26 is normal for preterm infants at term equivalent age.